And thank you for the invitation today. I'm delighted to be here to contribute. I'm sharing this talk with my colleague Robin Ferner, as you can see from your slides. He and I have been collaborating, discussing ideas about definition, classifications, and other matters to do with adverse drug reactions and medication errors for several years. The brief answer to the title of the paper that I've been asked to address is no.
Thank you very much, Nancy.
It's a pleasure. I hope to persuade you that that is so. These are potential conflicts of interest that are relevant. Well, errors have been defined by many different people, often whimsically. This is Ambrose Bierce and John Cage, the composer of 273 Seconds of Nothing. But there have been serious attempts to define errors. This is a paper that Robin and I published in 2006 in Drug Safety, in which we reviewed terminology and medication errors as a whole, and as part of that, tried to formulate a definition through a systematic review of other definitions, as well as etymology and usage. And I'm going to take you through that briefly. We've discovered about 7 or 8 definitions of medication errors. This is the first one that we've come across from Barker and colleagues in 1982. There may be earlier ones, and if anybody knows of them, we'd be interested to hear. The definition says that a medication error is a dose administered to the patient that deviates from the physician's orders. Well, of course, an error is not a dose. It's not a definition of an error. That needs to be rewritten, and it's not difficult to do that. One can say the act of administering a dose. That would be a definition of an error, a possible definition. Incidentally, it's not only physicians who make errors, as somebody may have suggested before. Many people involved in the medication process can make errors, and I believe that physicians should not rely, for example, on pharmacists to correct their errors. They should not be making errors in the first place. But this definition examines only that part of the process subsequent to the writing of the prescription. It doesn't deal with all the pharmaceutical matters we're aware of, the manufacturing problems and so on. It's very restricted. In addition, imagine the case where a doctor prescribes 250 milligrams of digoxin, but the nurse corrects to 250 micrograms. An error has occurred, but not in the administration of the drug, and that should be counted. The implication is we should include all medication processes when we're thinking about medication errors, not merely writing the prescription. The next definition we've come across is from the American Society of Healthcare Pharmacists, I think it is, 1993, and they talk about episodes in drug misadventuring that should be preventable. I'll come back to preventability through effective systems controls involving, and then a whole list of people whom they think ought to be involved. So what's the problem with this definition? Well, the first problem is that misadventure does not mean error, or not necessarily. This is the Oxford English Dictionary definition: an ill-conceived, misguided, or regrettable enterprise. Well, you might describe an error as such, but you might also describe, for example, the misuse of recreational drugs as such. And one would not classify those as errors in the context of medication errors, errors though they may be of a sort. The implication here is that one needs to define error very carefully, and we'll see that that's not always done. I believe that preventability is not relevant. I'll come back to that. And I think that it's not necessary to define who is responsible. That's not part of a definition of an error. It's important to know, but it's not the definition of a medication error who makes it. Here's the next definition we've found from Bates and his colleagues, 1995. He says, a medication error is any error occurring in the medication process. I don't know what you all think about that. People think that's a useful definition of an error. In fact, it's a circular definition. Here's our definition of a circular definition, one that uses as part of the definition a term or terms being defined, and the description below that is a more formal lexicographic description of a circular definition. Here are some examples. Dr. Johnson, in his 1755 dictionary, defined a hind as the she to a stag and a stag as the male of the hind. Doesn't tell you what a hind or a stag is. Not a very helpful pair of definitions. To be fair to Johnson, he tells you also that hinds and stags are members of the red deer family, so he is helpful. But taken on their own, these two definitions are circular and do not help. To define a medication error as an error in medication is of no value whatsoever. I hope that's self-evident, although some people to whom I've said this have not immediately appreciated it, which is surprising. So this definition is not helpful. It's circular. And the implication is we should avoid circularity. Here's Dean and colleagues in 2000 now, defining a prescribing error, but we could base a definition of medication error on it as a clinically meaningful error occurring when, as a result of a prescribing decision or prescription writing process, there's an unintentional significant reduction in the probability of timely and effective treatment or increase in the risk of harm. When compared with generally accepted practice, I'm stressing the bits that I think we need to pay attention to. Clinically meaningful, generally accepted practice. Incidentally, in passing, there are two things to say. Firstly, this is not a definition. It describes when an error occurs. It doesn't define it. Secondly, it importantly distinguishes between decisions and writing. And I think this is important to distinguish these two. And I prefer to talk about prescribing faults for the decision-making process and prescription errors for the writing process. And the word prescribing in English is ambiguous. So I've rewritten this a little, we needn't pay attention to that, to try to make it or bring it towards being a proper definition. But the problems are, firstly, that it includes diagnostic errors that are appropriately treated. That wouldn't be a medication error, but it would be a diagnostic error and should be properly classified as such. It also restricts errors to clinically meaningful outcomes. But as we all know, it's important to log errors even if there is not a harmful outcome. And the benefit-harm balance may or may not be affected, but the fact that an error has occurred is important because it may mark the propensity for an error on another occasion, which may be important. So one should not exclude clinically unmeaningful, if that's meaningful, outcomes. And as I said, it covers only prescribing decisions and prescription writing, but one could extend it. That's not a main problem. So the implications of this are that the clinical outcome is not relevant, whether harm occurs or not. And as I've said before, one should include all processes. Here's Koshal et al. It's Bates and his colleagues again in 2001. Again, slightly different, but a circular definition, errors in, and listing the various bits of prescribing that they think are important. Taxis and Barber in 2003 defined an intravenous drug error, and again, one could extend this to medication errors, as a deviation from a doctor's prescription, the hospital's intravenous policy, or the manufacturer's instructions. Well, the problem with that is the policy may be wrong, the instructions may be wrong. So deviation from incorrect policies and instructions may not at all be an error. And conversely, no deviation may indeed be an error. So relying on standard or recommended practice or advice is not a touchstone for defining an error. The National Coordinating Council for Medication Error Reporting and Prevention says that a medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm. Leaving aside the question of harm or non-harm, and the question of who is in control and who makes the error, this implies that all preventable events are errors, but that's not the case. We all know of preventable events that were not errors, and conversely, we know of errors that were not preventable. So relying on preventability as a touchstone for defining a medication error is not helpful. And I think this is a widespread misconception. Robin and I have written at length, and I'm not going to discuss preventability today, about a definition of preventability. I'm of the view that it's exceptionally difficult to reach a substantive definition, a stipulative definition of preventability, and that one has to do it operationally, but that's another matter. Finally, Lisby and colleagues, in 2012, carved a definition after they had performed a systematic review of the literature, which I'll show you in a minute, and they came up with a circular definition. surprisingly, after having thought about it, they said a medication error is an error in the stages of the medication process. So I think that is not helpful. So how should we define a medication error? I think it's difficult, and I think we should start by defining medication and defining error. That's a beginning at any rate. These are definitions from the Oxford English Dictionary, and English has a problem with nouns such as medication. Prescribing, I said, was ambiguous. It can mean different things. It can mean writing the prescription or deciding what to do. Prescription can be a prescription or the act of prescribing. Similarly, medication is ambiguous. It can be a count noun, a medication, which is a medicine, a medicinal product, but it can also be a non-count noun, the process of medication, the action of treating medically, treatment with a medicinal product. And we've defined medicinal product elsewhere, and I won't go into that. But that's what we're talking about today. We're talking about the process of medication when we talk about medication errors, not the medication itself, although the medication itself may indeed be involved in the error, of course. I've taken this definition of error from the work of James Reason, the doyen of psychological studies in error, and he defined an error as the failure of planned actions, to achieve their desired ends without the intervention of some unforeseeable event. That's important, because with the intervention of some unforeseeable event, it may be that no harm occurs, and yet an error has happened. And Reason recognizes that, as I've interpreted in this context. So, from the brief survey that I've shown you of the previous definitions and a little bit about the meanings of the words and how they're used, we come to have a list of things that one ought to define or include in one's definition of a medication error. Firstly, we should define error carefully, and particularly if we can, indicate how an error can be recognized, because there is a difference between defining something and using that definition to recognize when an error occurs. That's really the difficult bit, I think. We should include or at least imply all parts of the medication process, and we should include or at least imply all outcomes, whether harmful or otherwise. There are also things not to include. I've suggested that preventability is actually not correct. It's not relevant for reasons that I've stated. The individual responsible is important to know, but not relevant to the actual definition of medication error. And standard or recommended practice or advice may not be helpful. Finally, before we come to a definition, there are certain long-standing principles, lexicographic, linguistic, philological principles of definition, 5 major principles that I've listed here. Firstly, you have to encompass all possible cases if you can. The word finis, from which we get our word define, in Latin means a boundary. And what you have to try to do is to set a boundary around the thing that you're defining. And the boundary should not be too narrow. It should include everything that's relevant, but neither should it be too broad. It should not include things that are not relevant or not immediately relevant. For example, the people involved in making the errors. It should, if possible, use commonly understood language. It's not always possible in technical definitions to do that, but one should strive to do so. One should, as I've said, avoid circularity. One should use positive attributes, not negative ones. For example, one would not define wisdom as the absence of folly. One should say what wisdom is, not what wisdom is not. That's an important principle. And finally, one should try to specify the essence of the thing. The Latin word esse means to be. What is this thing? What is its essence? And this is an Aristotelian principle. Aristotle called it totienai, that which the thing is, literally. What is the essence of the thing? Can we get at the essence of a medication error? Well, based on all of this, Robin and I carved an error which we published actually in 1999. This was the first substantive publication in Lancet in 2000, and we suggested that a medication error is a failure in the treatment process, taking from James Reason that word failure, that leads to or has the potential to lead to harm to the patient. Some notes on this. Well, a failure signifies that the process has fallen below some attainable benchmark, and that will be different depending on the nature of the error and needs to be defined We have a definition, but we also have the recognition problem, and these two things are separate, one following on from the other. It might be, for example, to take a simple case, that an error would be made if in writing the name of the drug down, you spelt it wrongly, within reason. That might be an attainable benchmark. And one might define certain errors of that kind as being trivial and others as not. And failure is also the criterion whereby the error is recognized. So it seems to be obvious from what I've said. The treatment process is when you decide to adopt treatment for symptoms or their causes, or to investigate or prevent a disease or some physiological change. It doesn't have to start with the individual patient. It could start with the principle that we want to treat a condition with a particular medication. And the pharmaceutical formulation would then come into the process. It doesn't have to include only therapeutic drugs. It can include preventive medicines like oral contraceptives. It can include replacement therapies. It can include investigative measures like radiographic contrast media. It might even include cell therapies if you wanted it to. And it includes all the processes that we know about that don't need to be mentioned in the definition but are implicit. Has the potential to lead to harm. I've already been through this, coming out of reason's observation that unforeseeable events can prevent harm. Even if harm was going to occur, the error is still there and is important to log. And note, we don't specify who makes the error. We don't talk about preventability. The Australian Commission on Safety and Quality in Healthcare adopted this definition and added a clause. They said, and includes an act of omission or commission. I wasn't sure when I first saw this that that was helpful, but on reflection, I think that it is useful, at least to remind people that errors can occur by not doing something, just as they can occur by doing something. So I think that's probably a useful addition to the definition. Now, you and others did a study where they took definitions of all sorts from all over the literature, 160 websites and so on, a massive task of surveying the literature on definitions. And they created a handful of scenarios by which they tested the definitions of medication error, and the Australian definition scored top. Now, there are limits to this study. It was rather small in terms of the scenario analysis, but it sets a standard, I think, for further investigations into the uses of definitions and testing definitions. Plenty of people write definitions in reports and the like, and none of them is ever tested. And I think we should be testing our definitions using scenarios and real cases to see how they stand up in the real world. The Australian definition did well in this study at any rate. Here's Lisby again, who produced that circular definition I referred to. And they did this. It was a Delphi study, and I have firm views about Delphi studies. But it was based on a systematic literature review. And I'll show you the results of their literature review. They looked at 45 studies that are tabulated in 3 tables in their paper. In 17 cases, the definition that was used in that study of medication errors relied on preventability. And in 16 cases, it was the circular definition, an error in the medication process. The rest were a variety of things. Interestingly, the variants of failure were used in 5 studies, and Lisby et al. Seemed to think that failure was not a useful way of describing an error. They thought error was a better way of describing an error. So, and that's what they said. The implication being that we need a standard definition rather than letting individual researchers make their minds up. Sarah Ross and her colleagues from Aberdeen did a systematic review of prescribing errors in this case, committed by junior doctors, and they found that in all the studies that have been published, there was a range of 4 to 82%. I don't believe it can be as wide as that. Something is wrong in these studies. It may be variable from place to place, sure, but 4 to 82%? Unlikely. And Ross attributed this to variation in definition. And they said it's vital that future research is well constructed and generalizable using standard definitions and methods. And I think I agree with that. So here's the definition that I've come up with at the end. It's a slight variation on the Australian definition, and I commend it to you and for further discussion about what a really good definition should be and for further testing of the value of such a definition. A failure in the drug treatment process that leads to or has the potential to lead to harm to the patient and includes an act or acts, because often it's several acts in a system that fail to stop an error, an act or acts of omission or commission. That's what I offer for discussion. I think most of us have heard Alexander Pope's dictum from the Essay on Criticism, to err is human, to forgive divine. I much prefer Mae West's, but perhaps it reminds us that these are things we must avoid rather than espousing, or indeed waiting for somebody else to correct on our behalves. Thank you.
In the interest of time, I would like to ask only if there is one single question, and otherwise postpone any or refer any further discussions to the coffee break. Is there any burning question or a comment to make from the audience?
Very interesting, Jeffrey. Taking your definition to its logical conclusion, do you think it could even go back into the regulatory process so that errors of omission and commission could be, for instance, performed in the original drafting of the SPC? In fact, we could be thinking about a truly systematic definition, whereas previously we've just been thinking about the healthcare system.
That sounds attractive, but I'm not sure that it would help us when we come to study medication errors on the ground. I think that there would be a case for a systematic approach to errors at different stages in the development and regulatory process, as well as in practical clinical terms. But I think it is important to keep these separate aspects separate from each other. And I would say discovery and development is one group of actions that may be prone to error. Regulation is a second, and clinical use in all its aspects, from manufacture to delivery, is another area. But there's no reason why one shouldn't try to make that a stream of definitions that would talk to each other and inform each other.
Right, thank you.